Hello there, welcome to Perspectives. We have with us a seasoned medical practitioner and the director of Shield Specialist Hospital. He's going to be throwing some light on the health disparities we have in the society with a view to bridging the gap. It promises to be quite educative, enlightening and interesting, so sit back, don't go away. Hello and welcome back. We're privileged to have with us a seasoned medical practitioner, Dr. Ofegbu Victor Zubi. He is the medical director, Shield Specialist Hospital, a critical care physician and an occupational health physician. He's here to throw some light on health disparities in the society with a view to bridging the obvious gap. Dr. Ofegbu Victor Zubi, you're welcome on board Perspectives.
Thank you very much.
Some people out there may not understand what the term health disparities mean. Can you tell us what it means and, generally explain it?
The term health disparities refers to the differences that exist between different health populations and the difficulties that exist for them to access health care and the facilities of provision of health care in their immediate environments. In a nutshell, that's what health disparity is. Looking at the health population disposition, the population between the newly born to the aged, that strata of population, how much of these different age groups participate and access health care, what makes them to have difficulties. It could be gender, it could be age, it could be their ethnicity, it could be their race, it could be their geographic location where they are dwelling at a particular time. It could even be their sexual orientation, and probably sometimes the religion dispensations and dispositions that makes them to have difficulties or have easy access to healthcare provision.
Exactly. But fact of the matter is some people actually have difficulty getting good healthcare, quality healthcare.
Yes.
And who are the people at the greatest risk? Who are those most vulnerable to poor quality care?
In our environment, the women, the aged, the young, and the adolescent have some higher degree of disparity. How this happens with respect to the younger age, the infants and the newly born. Majority of times, young infants cannot access health care depending on where they are born. Take, for instance, the riverine, the waterlogged areas, in River State, for instance, where you say the water areas. A child born in those localities, various times they have ailments that they may not be able to easily access health care. And even when there is healthcare facility in their neighborhood, the specialist care is also devoid in such areas. So they may not easily access health care, and when they do, they don't get the best of such services. And because these facilities may not be even present in their location, they may have to travel far. They have to travel through risky environments, through the water. They may have to paddle through the night sometimes. And to access healthcare in the area that they have to get to, they are at risk of even losing their own lives. So sometimes, because of the distance they have to cover, because of the terrain they have to go through, most times they are left for dead in their areas, and they cannot get healthcare services accessible to them. Women, for instance, many women, they don't, if they don't have very healthy environments, their families are not very rich, they cannot afford to pay the healthcare needs. So they can't access the healthcare. Even when they know they have need for the healthcare, they can't afford to pay for it. So they they just make do with what is available that most times they won't want to pay for. So if there is no government facility in their neighborhood, most of them would just take care of themselves by themselves and depend on God to help them.
Okay. So you're saying that the root cause of this situation is poverty or lack of funds, or lack of finance? What exactly is the root cause? Let's hear from you.
Majority of the disparities is due to poverty.
Poverty.
Poverty, low socioeconomic status, the poor environmental conditions, and poor habitat where they live. Sometimes people live in shackles. In our environment, we call them bacha.
Bacha.
The bacha population most times is even much more larger than those who live in block buildings. And those people who live in bachas are not living in bachas because they don't want to live in good houses. It's just because of what they can afford.
Yes.
So it's, most of the time it's the financial power that
Yes.
determines what they can procure.
Well,
so that also makes them excluded from the health provision and the healthcare availability that is accessible.
yes, but it brings about the question, whose responsibility is it to address this problem? I mean, because the truth of the matter is, some individuals might say, oh, people have to work hard to be able to change their socio-economic status. But at the end of the day, some other people work very hard and they're not able to do that, probably because there are not enough opportunities available to them. What is your take on that? Whose responsibility is it to address this problem?
You know, health or healthcare is a fundamental human right.
Oh, okay.
Majority of times people look at it as it's your right to be alive. If you are alive, you have a right to live healthy. So who provides the healthcare? Who covers for healthcare? The government is the primary entity responsible for healthcare provision, accessible healthcare provision for the individuals, so that no individual is cut off from accessing qualitative healthcare. If the individual cannot afford, then there should be some level of healthcare that can be made available to that individual, such that they will not be cut off or disassociated from getting healthcare at their immediate environment and to the best quality available.
So you're saying the government is
Is primarily responsible for that.
Have they done enough?
There's so much to be desired. Government is left so much undone. You know, sometimes budgets are left to be decided by those who have interest. Health budgets are expected to be at least 20% of the national budget.
Okay.
But in our climes,
By whose standard?
WHO standard,
Oh,
yes.
okay.
But in our climb, sometimes we have 5%, 7%. So when you have 5% of national budget being allocated to health, there's little or nothing that can provide for.
Exactly.
So most of times you have people who have to fend for themselves by the possible means available to them. Sometimes they resort to their traditional means of healthcare.
Which is as good as no
As
means.
yes, not as good. And then you have faith-based healthcare provision in some environments.
Does that work?
Because you know, the issue of the disparity has to do with cultural belief systems and faith and religion. So most of these people resort to this not because it is the first option or the best option, but because they don't have any option.
That's what they're left with.
Yes.
Yes. All right, then just hold it right there. We'll be back with more on health disparities and bridging the gap. Don't go away. Hello and welcome back. We're here with Dr. Ofegbu Zubi Victor, and we are discussing health disparities in our society. So, Dr. Ofegbu, the government, some 10, 12 years ago, at least the government of Nigeria, introduced the health insurance scheme. And I'm sure the reason for that is addressing this problem, is to address this problem of disparity in healthcare. So, has that been effective?
When you attempt to attend to a problem
yeah.
wholeheartedly,
yeah.
it makes more sense.
Oh, so the problem is the wholehearted.
Yes, it was attempted without the strength to deliver.
What do you mean?
If I set out on a journey, I know where I'm going to. I know the easiest route to go there. I will almost certainly get to my destination.
Okay.
But when I don't know the route to go there, I invariably will miss my destination. I believe the Nigerian government set out to do health insurance without the proper setting for health insurance.
Setting?
Yes.
Explain setting.
The health insurance scheme that Nigeria involved 2001, thereabout, was more of public health setting for the public servants.
Okay. Yes.
That automatically cut off so many people. Only the civil servants who were able to access care from that.
Yeah.
And not even all the civil servants.
Yeah.
The civil servants that are only working in the federal system. The states were not involved. Even today, the states are not yet involved in health insurance. The health insurance scheme that was launched at that time was devoid of skills to supervise the system. They withdraw money or take money from the people who participated in it and lump this money into some account without proper delineation, without proper assignment. HMOs were created or were registered,
Okay.
who took up the responsibility to administer or midwife the insurance scheme. The majority of them had little or no knowledge
Yes.
about health insurance scheme and its operations.
Yes, and probably just went into the business because it was the
It
crave.
was lucrative.
It was the crave at
Yes,
that time.
it gave them a lot of funds to play around with. And the National Health Insurance Scheme that should midwife or be the umpire lacked the strength to supervise and prescribe the route to administer the health insurance. So many of the HMOs operated by themselves, the way they felt like,
Yes.
leaving the health utilizers, the patients, the Nigerians in limbo. Many of them don't access health care. And the providers of health insurance, the hospitals,
Yes.
are also shortchanged. And these are not all supervised properly. So you have the health insurance scheme that is expected to work, that is not working. You have the providers of health care, the doctors and the hospitals, expecting the system to work, but they're not getting the benefit of that system.
Okay.
And then you have the patients who are in this situation, as far as I'm concerned, the victims, because they've contributed their funds and they're not getting requisite adequate health care.
Well, I understand what you're saying, but we could very well say those with teething problems. I'm sure the situation has improved today.
Yes, to some extent, we will say it has improved. But the supervisory role of the NHIS is still lacking, because majority of the HMOs are still not sitting up and doing what they should do to make health available and affordable to the average Nigerian, because they've not moved any inch beyond this inception. The health scheme is still federal government parastatals that are covered. The states have not keyed in. And there's no law that has made them to see the need to key in. If they key in, it becomes more affordable, it becomes easily accessible, and it becomes more robust for every player to benefit from it.
Why have the state governments and the local governments not keyed in?
When
It
you say
should be
local government,
their-
you find out in our society, the local government seems to be killed. It's no longer existing. There's virtually no local government in existence anywhere.
Really, but they
Most local governments are serviced by the states to
Okay.
pay salaries of local government workers.
are. Okay.
So the states are the primary factors here.
Yeah, so,
So if the states key into the health insurance scheme,
yeah.
the health workers, the state civil servants would be made to contribute.
Yes, will be made to.
And then they will benefit from the health care that will provide for.
Okay.
But the states have not keyed into that.
And they are not being compelled by the federal government. The federal
As-
government doesn't have that power.
Right now, I don't have that information.
Okay.
Yes.
All right, but to a large extent, the HMOs have helped. I mean, it can't all be negative,
Yes,
negative, yeah?
they made provision for access to care and access to care and affordable care to some extent. But you know, it's not all health care needs that are covered by HMOs.
Yes.
They decide to choose which aspects of healthcare to cover, irrespective of the contributors' ailments.
Well, I believe that there is a pattern which is in existence worldwide. I'm very sure that even outside the country, there are certain ailments that are not covered.
Yes, certainly yes. But you know, in such climes, you have the government-run insurance schemes and the private-run insurance schemes. In our country, we have the NHIS, that is the government body, that is the umbrella body supervising.
Yeah.
Then we don't have any government agent operating as a health maintenance organization, the HMO. In the US, you have Medicaid, Medicare. That's government-run. And you have other health maintenance organizations that also provide for the insurance scheme.
Okay.
So clients and beneficiaries can procure their health insurance and then utilize their services.
Okay.
But here we have all our HMOs are privately owned.
Private, yeah, and that's a problem.
It's an issue.
Quite an issue, yes. Yes, I see reason with you.
So
there.
coverage is reduced. It's not as much as.
Exactly.
Because, for instance, cancer situations are not covered by most HMOs. HIV is not covered by most HMOs.
Well, but
Tuberculosis is not covered by most HMOs. When there are patients that have these conditions, the HMOs will decline to care because they will say it's not covered.
yeah.
They did not pay the premium that will cover for that.
And usually
And
there is no
it's easy.
premium that can cover for that.
Well, but these people are Nigerians who are sick.
yeah.
So there is already
a disparity.
disparity. Even though there is a seemingly health insurance in place.
But at least that's a step in the right direction.
Yes, the
Yes.
health insurance should be much more supervised
Yeah.
and much more robust.
Okay, Dr. Zubi, what is the acceptance level like with the people, the general populace, when it comes to health insurance and the provision that government has made for them when it comes to their health, which is, of course, the health management organizations and the healthcare agencies, yeah?
Yes, the people have accepted that, you know, when it's government influenced, the government edict that established the health insurance scheme, the people have accepted that. The problem the people have is that they are not getting qualitative coverage.
Okay.
So they get care in some areas, which, to my assessment, the cheaper medical needs are covered. When there are bigger fishes to fry, they have to fend for themselves, most times.
Because I realized that there was some general distrust, you know, when it comes to health insurance, particularly in Nigeria.
Yes, you know, every new system comes with a lot of questions and doubts. Nigeria never practiced such before. So when it was introduced, there was so many skepticism.
And
Will it work?
Yes.
Are we ready for this?
Exactly.
Are our systems functional enough? Are our people ready? Are they sincere? Is the government going to be sincere to establish and implement it to the letter?
Because of that, most of them did not even bother accessing the health care based on that.
Because the government also came with the initial plan to do for federal civil servants.
Only.
Their contributions were at source. They were
At
taking, the
source.
money
It
was
was made
taken
compulsory.
and it was made compulsory. So they had no option
Yes.
but to key in. But majority of people whose money was taken didn't even know where they were going to access care from.
Yes, they were not even educated.
They were not
or
educated
enlightened,
enough.
Yes.
They didn't know the hospitals that they have been attached to.
And even the hospitals and the
They didn't
medical
know the
practitioners were
clients.
confused
Yes.
as well. As
And
to
the detail of the
Yes.
operations was not made known. The fees were not made clear enough.
to the yes.
Nobody had a discussion. No training session was done. So people just got into it and learned on it as it went by. And you know, such things comes with a lot of destruction and a lot of stories will come around.
Yes.
Yes.
Okay. We'll take a short break now. And when we come back, we'll talk some more on the private practice of Dr. Ofegbu. Don't go away. All right. Dr. Ofegbu, has there been any research into these health disparities? Have there been like written work, you know, that people can refer to, articles and such?
In our society, the Nigerian environment, we lack data. our major problem is data collection is poor, very poor.
Okay.
Outside of these shores, yes, health indices are bound, and these are what drives the development of policies and establishment of health facilities and utilization. But for us, we have paucity of data collection, and researches are also poorly funded. Here, you hardly have research institutes that go into critical areas of disparity, looking into the nitty-gritty of health disparity and making these disparities, trying to bridge the gap between them and making provisions that will affect policies for the government. Most of our health research will depend on WHO extrapolations from Western research.
Okay. Western research.
Most of the information that we have are extrapolations. For instance, before you talk about health disparity, you should have a concrete data on your population. Nigerian population today is still a speculation.
Yeah.
We don't have a concrete number of how many Nigerians we are. We don't know how many children are under 5. We don't know how many Nigerians are women that are of childbearing age.
So do you mean you don't trust the last census results?
It's not, I don't even have the document that says this is our exact number. So coming to trust it is another question.
Yeah, but the results were announced.
The Population Commission themselves
Yes.
declare that the census is not concrete.
It's not concrete.
Yes, because we are supposed to have census every 10 years, isn't it?
Yeah.
The
I'm
last
not
was
sure about
what
that.
year? Our indications for health care in this country are on speculations. We don't know how many children have autism, for instance, in Nigeria. How many children are autistic?
But
How many children have sickle cell disease, sickle cell anemia in this country? We don't have that data.
But isn't that the function of the Federal Institute of Research? We have a research institute that is federal, right?
Yes, but there should be a collaboration between the federal, the states, and the local government,
Okay.
the health centers.
Okay.
This data should be collated and then taken up there so that every information is brought together.
Synchronized.
Yes. If we don't have them in local government health centers, they exist in theory. Most of the health workers there just go to work.
Yeah.
They're very much underutilized.
Okay.
The general hospitals, most states' general hospitals are not existent. Most states depend on the tertiary institutions in their states for primary health care. Such situations will not give us enough background to know our health indices.